Now,
Namaskar to all MOS and non-MOS members who are joining us for this wonderful webinar on Phaco, the basics. We've got some masters of Phaco with us, and I'm sure you must be just waiting to hear from them on different aspects of Phaco and how they deal with the problems that all of us face at some point of time or the other. But before we go on to our actual webinar, I'd like to share a small something with all of you, which is I don't think it is visible, is it?
It is visible, ma'am. I think you have to go and start.
Okay. Thank you all so much. This is the first teaser, the first look of what our MOS virtual conference, we've named it MOS WorkOn 2020, is going to be like. I would now like to request our two moderators, Dr. Jayant Sarvate and Dr. Shirish Thorat, to please introduce our illustrious speakers.
Welcome all the distinguished speakers. The task of introducing all the distinguished speakers whom we all know well, and I request Shirish to give the introduction for first two speakers.
Thank you, sir. I am happy to introduce Professor Dr. Amar Agrawal, sir, who as such needs no introduction. He is the most innovative person in the field of ophthalmology. He has pioneered many novel techniques. To name the few, he was first to remove cataract through 0.1 mm tube, first to implant good IOL, first to use trypan blue as the epiretinal membrane stain, discovered no anesthesia cataract surgery. He, along with Dr. Harminder Singh, had pioneered pre-descements endothelial keratoplasty, and IOL scaffolding is extremely useful innovation. He has written more than 50 books which have been published in various languages. He was president of International Society of Refractive Surgery. He has received many awards, prominent amongst them the Baracker Awards and Kelman Awards. He is now chairman of Agrawal Group of Hospital, which has many branches in India and overseas. So friend, we look forward to his lecture on sticky situation during Phaco. Let me introduce another speaker, none other than Dr. T.P. Lahane sir. And it is great honor for me to introduce Padma Shri Dr. T.P. Lahane sir. His name in itself is an introduction. He is a perfect example of how a single person with his skill, will and dedication can contribute in a great way to the society. He has done nearly 1,75,000 cataract surgeries so far and still counting. He is pioneer of advanced phaco and SRCS surgeries in eye camps in the rural areas. He has encouraged many ophthalmologists from smaller places and inspired them to present their skill on larger platform. He has shown his mettle as a good administrator, as the Dean of JJ Hospital, and at present he is Director of DMR. In acknowledgement of his extensive social work, he has awarded Padma Shri, the highest civilian award by the Government of India. If all these achievements were to be narrated, it will take one whole webinar. So I am cutting short the introduction. And today he is going to speak on hard black cataract, popularly known as black cataract. Thank you. May I request Dr. Jain sir to introduce rest of the speaker, please.
Thank you, Shirish. I have a pleasure in introducing Professor Su Fei Chi, a distinguished professor of clinical education in ophthalmology in Singapore National Eye Center. She is a senior consultant of ocular inflammation and immunology service. Professor Chi's research interests in complicated cataract management. In the field of uveitis, she has been president of Asia Pacific Intraocular Inflammation Study Group since 2013. She has authored over 200 peer-reviewed scientific papers and many book chapters. Very distinguished speaker in all the international conferences. She has been given a Best Teacher Award in SNEC in 2005, then again the Outstanding Clinician Award in 2011, and in 2018 a gold medal. So such a illustrious professor we have with us. It's our great honor. It's also my great honor to introduce Professor Ragini Parekh. I'm really thankful that she has come for this MOS webinar. She is a professor and head of the Department of Ophthalmology in Grant Medical College. She has got honor of having highest cataract surgeries, lady surgeon in India for last 7 years. More than 75,000 cataracts she has performed. She is also having the records of many eye camps and made a world record of operating 249 sutureless cataract surgery SICS in 3 days. She has been felicitated by innumerable awards, Giants International Award, a Shatayushi Puraskar, a Seva Puraskar for selfless community service, gold medal for community ophthalmology, felicitation by Honorable Women's Day, and Oration Award at Miami, Florida, to name a few. She is also a scientific committee chairman in BOA, and we all know her, and we are fortunate to have her inputs in this forthcoming session. Welcome all, sir, and I request Professor Amar Agarwal to start his talk.
No, just a minute, Dr. Sarvati.
Yeah,
First,
okay.
you two also have to be introduced as the
Okay.
So I would request Vardhaman to have the pleasure of introducing both our very eminent auditors.
Thank you, ma'am. So I have of course great pleasure introducing both our eminent moderators, Dr. Jain Sarvate sir and Dr. Shirish Brat sir. Dr. Jain Sarvate sir, of course, all of us know that he has been in practice for last 38 years in the city of Satara. Dr. Sarvate sir has been trained with Dr. Nagpal sir as a video retina surgeon, but after that he also got trained with Dr. Rayas sir in IOL implant surgery. He has been Rupture sir in advanced cataract surgeries. He has been one of the earlier proponents of phakic lenses, keratoconus CTR treatments, as well as surgeries in Western Maharashtra. And of course, he has been honored and invited in many state and national conferences. So thank you very much, sir, for accepting our invitation to be moderator for today. Our second moderator is Dr. Shirish Thorat sir, who is currently the Joint Secretary and will be taking over as Secretary of Maharashtra Ophthalmic Society next month during the virtual MOS. So Dr. Shirish Thorat sir is been practicing in the Society. He's a very important cataract and refractive surgeon. He has been actually awarded in Hanjao in APSDRS with the Best Video Award, and he has been also felicitated by the AIOS International Hero Award because of the same. Dr. Thorat has been at forefront of many innovative videos. He has presented a lot of papers and publications in many journals, and we are also very thankful to Dr. Thorat sir for accepting this invitation to be a moderator for this landmark webinar. Thank you very much. And
Thank
here,
you. Thank you very much. And now it's over to you, Dr. Amar, for your presentation.
Yeah,
Thank you
please.
so much.
Thank you very much. First of all, I'd like to thank MOS in a very, very big way for this lovely webinar, educating so many people. And Professor Malik, you are leading the front with Jayant, Vardhaman, Shirish, even Santosh Bhide, who has done so much work. But I think two big doyens here are Professor Lahane and Ragini, and the third is none other than this lovely lady who's one of the greatest surgeons I've known, is Soon Phek Chi from Singapore. One thing I'd like to tell MOS is Professor Ragini has become the Vice President of the Indian Intraocular Implant and Refractive Society, and it's a very big honor for the IIRSI to have her as the Vice President of this, and the next 2 years she'll be the President soon. So I'll now start sharing my screen.
I request everyone else to please
Check if my video comes for you. Is the
Yeah, it's visible. It's
visible? Is it full screen?
Yes, it is.
Okay, so let me, I thought I'll show you on phaco complications. Now this patient, you can see, has a small, here is, I have my ring also, and I'm placing it above the ring and above the iris. Once that's done, the IOL is acting like a, before you can say bingo, that nucleus is gone. Now, once my nucleus is gone, I made my scleral flaps already before. I made my sclerotomy. Now, the problem is I need to transfer this IOL, which is above the iris, to behind the iris. The problem, understand it, it is getting stuck. You see on the top there, it's getting stuck to the eye ring, as you can see there. And it is preventing me from doing the handshake technique. That's the challenge I'm facing right now. And in the bargain, I knew I'm in trouble, so I dropped it. Now I have not externalized the first haptic. So I'm going for the second haptic. Obviously, remember, my first haptic is still inside the vitreous cavity. So this haptic drops, my whole IOL has got to drop then. So I'm trying to see that I don't drop this, catch the tip of the haptic. Once the tip is caught, I've externalized. Now, once I've externalized the first haptic, I now will catch my second haptic. And you see there, catch it anywhere. Now move it from one hand to the other. Move it from one hand to the other till you catch the tip of the haptic. Once the tip is caught, pull it out. So this is the handshake technique. Now my question comes, what do I do with the ring? Now when I wanted to remove the ring, I made a mistake. Always dislodge the ring from the iris. Then only remove the ring. I have not dislodged it from the iris yet. So see now what is happening is, when I'm trying to pull on the ring, it's still attached to the iris, and look what I've done. I've created an iridodialysis. That's the next problem which I've created. Now, I have a problem of having an iridodialysis. My ring is still in place. Now I'm going to dislodge the ring from the pupil margin. So I'm using my two hands to dislodge it. Then only I will remove the ring. Now in the bargain, what's happening is, my ring is going south, going down. And at the same time, notice my haptic is also coming off. So my assistant has run to catch the haptic before my IOL goes down. Now, before my ring goes down further, I'm trying to bring it up anteriorly and bring it above the iris. Once it's above the iris, now I go in with this injector, same injector which we injected the ring, and explant the eye ring. Once my eye ring is out, I realize my amount of haptic is externalized is less, so I'm coming more anteriorly to make a anterior sclerotomy so that I'll have more haptic externalized to bring the haptic more tuck being inside the eye. So I'm catching the haptic, again the tip, pull it out through an anterior sclerotomy, and I already have an iridodialysis there, so it's okay. Now I create my Gabor-Charier's pocket with the 26 gauge needle. Now I'll tuck this haptic inside And now you can see on the other side I've tucked. Now remember, both sides are tucked. My posterior sclerotomy, I will just suture back. But remember, case not over. I still have an iododialysis. This is the hang back technique, and I'll talk more on it subsequently. Inject air and finally seal everything down. So you can see now what I'm going to do now is transfer it from above the. So I'm trying to take it, transferring it, but look at it. It's so full there. And I'm trying to dislodge it. It's not happening. Now look carefully. I try to make an incision. My incision has cut the haptic. I have a large iris defect. So this technique which we started is the 4th row pupiloplasty. So it's called single pass 4th row pupiloplasty or SFT. From one side, remember there is straight through clear cornea, I passed a Proli needle. From the other side, I have a paracentesis. Paracentesis is needed only on one side where you have a 30 gauge needle where I am now. I pass the 30 gauge needle into that. Now I will railroad the two. Please remember, do not do paracentesis on both sides. It's not needed. You can go through clear cornea on the top. The one below only needs the one which is towards you, needs the paracentesis. Once I've done that, I bring this loop out. This is a single pass. Pass it 4 times. Once I passed it 4 times, you can see I've just tied it and that's over. So normally you do 3, 2, 2 throws or something like that. Here you've just done once. It's 4 throws and that's it. It's so simple. Anyone watching this webinar from MOS or anywhere in the world can do this procedure. I've done one more here on the other side. Now you can see I've done the 3rd one. See how the pupil has become smaller. But remember, there is an iridodialysis defect still, which I have created. So a new technique we just started is called the Trocar assisted hangback technique, which will be published in the EGO also. Now watch a simple procedure. Here I'm going to use a Trocar. I'm passing the Trocar into the eye. Now I'll take a double-armed Proli needle. Once you have a Trocar, it's very easy to pass. It passes through the iris, and from the other side, you take a 30 gauge needle, railroad the two and bring the suture out. Now you take the second arm of the same Proli. It's double-armed, you know. Same procedure is done. Now all you do is pull. Once you have pulled both ends, now tie it, and that's game over. So now remember, simple way to do an iridodialysis. So watch, I'm fixing a Trocar inside. This is a Trocar AC maintainer. Now I'll pass my double-armed Proli needles. Look at that. That's the first thing which is going inside the eye. Because it is a Trocar there, it's very easy to direct it. It goes through the iris, and from the other side you can pass a 30 gauge needle and railroad the two so that it comes out in the correct place wherever you want it to come out. And you'll see me doing that just now. Once I have brought out the first Proli needle out, I will now do the same for the second thing. See, the first needle has come out, the suture is going out. Now I'm passing the second one. Again on the other side of the iridodialysis. Again it will come out next to the area where the first one was, and all I have to do is tie it. Now see, when you tie an iridodialysis, remember what happens. The whole iris goes to one side. So there is a defect created. So again you do a 4th row pupiloplasty. So this is called the 2-fold technique. In other words, I've done a Trocar assisted hangback followed by a single pass 4th row pupiloplasty to make my defect back to normal. But remember, on the top, I still see an iridodialysis defect. So again, notice I'm fixing a Trocar on the top there, which goes inside the eye. Once my Trocar is 180 degrees away from where my iridodialysis is, watch the technique again. I'll pass the double-armed Proli needle. So remember, any of you who have an iridodialysis, try this technique out. It is so simple. All you need is a Trocar and you need a double-armed Proli needle. So you see now I passed it through. This first needle is coming out. Now I'll pass the second one. If you don't have a Trocar, what will happen is it sometimes gets stuck in the corneal incision there. Now you see I passed the second one there. I brought it out. Now look, I'm going to pull on the suture and see what will happen. My whole suture will pull on the iridodialysis and the defect is solved. Look at my Purkinje image. I'm adjusting it so my Purkinje image P1 is bang centered. The rest of the procedure is very simple. All I have to do is apply my fibrin glue and seal everything down. So I'll move on to my 3rd case, which I thought I'll just show you in a second. And this is my last case, which I thought I'll show you, in which I hope the video is coming.
Yes, it is.
Okay. Now, this is the last case which I wanted to show you. Again, a crazy case, but look at the cornea. It is absolutely white. I made my flaps present there. And here, this was a top surgeon who had come to me, and somebody had implanted in him an ACIOL. So you see there's a scarring issue present there also. I'm taking off this fibrotic area in the front, in the epithelium and all. Then I fixed my trocar inside from the back. Now notice, I've got my flaps which are not 180 degrees. So I'm making my flaps 180 degrees so that they match each other. Now I have an ACIOL inside. So before I go inside, I want to check how is the retina or anything, because somebody might have left something behind also. So I go inside, do a posterior vitrectomy, and you can see the disc, everything there. Once everything is clear there, I make my scleral tunnel incision, and I'm going to take out this IOL. The problem with these ACIOLs are, they are so badly stuck, like in my previous case I showed you. So you have to take it out very, very carefully. I don't want any bleeding to occur. And this has got some crazy 4 loops inside which lock onto the iris very badly. So I've removed them in piecemeal. You can see it's come out broken, does not matter, but still some pieces are inside. So I'm taking out some haptic which is there, and still there's one more piece which is locked onto the iris there. See there? It's locked onto the pupil, to the iridectomy there. I'm taking it out, and I'm hoping that there's no bleeding which occurs, because I don't want any bleeding to occur, but invariably, see, the bleeding has started. Anyway, touch wood, everything has gone away till now. All I do is done some vitrectomy. Now remember, I have to do my glued IOL. So I'm going to now take my IOL inside, and I am catching the haptic. Since I already have a large incision, I might have implanted like a non-foldable IOL. One haptic is out. Now I go in, take out my second haptic, transfer it from one hand to the other, do the handshake technique, and you can see there I've caught the tip of the haptic and pulled it out. So far, so good. Now, once I've done that, I need to make my pupil smaller. Why? Because I want the air to remain the eye. I don't want any astigmatic problems. So I have pinhole pupiloplasty effect. So I do this 4-throw pupiloplasty just to repeat it. One side straight Prolene, other side 30 gauge needle, railroad the 2, bring this loop out. That's single pass. Now remember the number 4. 4 times you pass, that's all. Pull, game over. So that's game, set, and match. So you see now I'm doing the same thing, straight Prolene through cornea, down from the other side 30 gauge needle, bringing it out, bring the loop out like I showed you in the previous case. Here you can see the single pass coming out. Once that's come out, remember the number 4 times, pass it on the same direction, remember that, and then that completes it. Why am I doing this? I don't want my air going back. 1. 2, any closed angle will become an open angle. 3, if there's any astigmatism that gets anyway neutralized with the pinhole defect, my air remains there. Now look at this. This is the cornea. You're looking at the endothelium. I create this bubble. This is a pediatric bubble. Remember, this bubble does not go to the periphery. So where is the air? You have endothelium, you have desmase, you have the duas or the predesmase layer, then air, then the stroma. That's a pediatric bubble. If it went to the periphery, it was a DMAC bubble. You will have endothelium, desmase, air, and then predesmase layer. I enter inside this pediatric graft, inject my trypan blue staining. Now I cut it fully and I've got my pediatric graft ready. All I have to do is inject it inside. So I'm fixing another trocar in the anterior chamber for air. Once that's done, you'll see me now injecting this graft inside. So before I remove that, I'll take off all this bad endothelium which is there. So you can see the desmotorexis being done with air continuously being inflowing inside the eye through the trocar AC maintainer. Once that's done, I take the graft just like how you will inject a DMAC graft or an IOL, take it inside a normal injector, and I've injected it inside, unroll it, and fix the graft back in place, just like you do in a DMAC. We never do DMAC in Agarwal hospital groups. We only do PDAC. The reason is I use only young donors. Second thing is the tissue is very easy to manipulate. Look how I'm moving it. You cannot move a DMAC graft like this. Now, once everything is done, sealed it down. Now the question comes, how did this patient behave? So look at, see the final picture which I thought I'll show you before I close up this presentation is to see how this case ended like. So this is how the case looks at the end of the day. Now let's see, once I've done everything up, I'm just going to show you the final picture. Look at the patient 2 weeks post-op, 636, 618, 1 month post-op. Now you can see the patient 2 months post-op, and finally you will see the patient 3 months post-op, 20/20 vision. And you can see the final picture, 9 months post-op. See the pre-op and look at the post-op, and you will see such a huge difference in this. And the last thing I thought I'll just show you is, this is the latest book which is coming out on iris repair and pupiloplasty, which has just been released by Slack. And we also have a book by JP, which is on the predestined endothelial keratoplasty, basically showing you various techniques on how to perform this procedure. I'll now stop sharing my screen, and I want to thank you all once again for this lovely thing of MOS webinar.
Thank you so much, Dr. Amar. As usual, your videos and your topics are marvelous. There's no other word for them. I think they're so innovative that I think you dream up something to manage every problem that comes up. So now it is my pleasure to request Professor to share the screen, and she has some wonderful videos. I know, I've heard her before.
Over to Professor Chi.
I think you have to unmute yourself. Please unmute yourself.
I hope you can see my screen now.
Yes, we can. Just make it full screen. Perfect.
Thank you very much for inviting me to speak. And I'll be talking about the management of uveitic cataract. So these are my financial disclosures with no relevance to my talk today. I think the internet's a little slow. Okay, so cataract in uveitic eyes is really a common complication, and the outcome depends on the uveitic diagnosis firstly. Secondarily, it depends on the pre-existing structural damage in the cornea, perhaps the optic nerve or the retina. And very importantly, what you can handle is really the perioperative management of inflammation and surgery. So first of all, when you look at the patient who has got uveitis and is presenting for cataract surgery, the first question you need to ask is the cataract responsible for the poor visual acuity? You want to assess the patient's visual acuity potential. So you want to look at the cornea endothelium, that it should be healthy. The optic nerve, the OCT, can help you to look at the optic nerve as well as the macula. You want to look for macular edema because this may be the reason for the poor vision rather than the cataract that may also be present, right? There may be a neovascular membrane that all can be treated before surgery. And you want to set the patient's expectation correct so that they do not think that they're going to achieve fantastic vision when they have limiting factors. So one good way of assessing the risk for complications, because we know that hypotony is one of the most serious complications, is to assess the state of the ciliary body, especially if the patient tends to have brittle ocular pressures. So we do UBM, and you can see a healthy ciliary body with intact zonules. And you can see a patient here with atrophy of the ciliary body with tractional membranes and the suprachoroidal cleft. And you can see that the iris is adherent to the ciliary body. And this is another patient with atrophic ciliary body and suprachoroidal cleft. And this is a patient who has got missing zonules. So this is really very useful for assessing the risk of hypotony as well as the zonular attachment. Now, in patients who have had repeated intravitreal injections or previous vitrectomy, they may have been lens touch, and you really want to look for this when the lens is still clear. And in the case here, you can see actually there has been actually a needle injury to the posterior capsule. And in this case here, you want to get the vitreoretinal surgeon on standby in case this nucleus drops. Right. Other considerations include pre-existing glaucoma surgery site. You want to avoid a trabeculectomy site or a tube. You want to look for peripheral anterior synechia, band keratopathy that you might want to address before you do the cataract surgery. So the timing of surgery is important to have the eye quiescent for a minimum of 3 months. However, if you are able to control the inflammation and you're short of that 3 months, you can run intravenous methylprednisolone 1 gram prior to surgery to get the eye quiet. That's for the surgery and to continue the patient on high dose of oral prednisolone thereafter. However, for Behçet's disease that tends to have a very severe panuveitis, you want to have the patient quiet for at least 6 months. If you have a flare meter available to you, it's useful to use this for monitoring the flare to get it to the lowest level before you attempt surgery. Now, whether or not to implant a lens, it's often a debate, right? So the IOL is not contraindicated if you have optimal control of the inflammation. However, if the inflammation is barely under control and you need better not to do the surgery then if you wish to implant a lens. However, sometimes we do have patients with very intermittent lenses and you need to take them out quickly to prevent complications. You may then have to start them on biologics or strong immunosuppressive therapy to get them under control. Just having steroids alone on board to control them is really inadequate. Right, so if the eye is truly optimally controlled, we can then consider in the back implantation of the lens. Never put it in the sulcus. You want to avoid silicone lenses, anterior chamber lenses, and definitely in pediatric cases less than 2 years old, these should be avoided. If not, you will end up with complications like what we see here, reformation of pupillary membranes after the cataract has been removed, or optic catcher like this. It's better to leave the eye aphakic. You can then refer the patient to a cataract surgeon to have a lens fixed to the sclera at a later date. So considering the anti-inflammatory prophylaxis, this is really only necessary if you have to manipulate the iris because the pupil is too small, patients who have had previous macular edema, patients who have panuveitis, inadequately controlled uveitis, and definitely if this is the patient's only eye, you do not want to take chances. Now, with regard to anti-inflammatory therapy, I always give topical NSAIDs even for the standard non-uveitic eye. You want to consider perioperative oral steroids, usually 0.5 milligram per kilogram body weight, 3 days prior in those indications I mentioned earlier. And today I prefer to give intraoperative prophylaxis, which takes the form of intracameral dexamethasone, 0.4 milligrams in 0.1 mil. And if there's posterior segment inflammation in the past or risk of macular edema, I would then give intravitreal triamcinolone 4 milligrams in 0.1 mil, or preferably today, and if the patient can afford it, dexamethasone, a drug delivery system, and that's marketed by Allergan as Ozurdex. So in terms of which is better, systemic or intravitreal TA or DDS, generally it's been shown that really there is no difference between systemic or intravitreal triamcinolone acetonide prophylaxis and systemic against Ozurdex, all right? So they are really much the same. It really is your patient's affordability, and generally I would prefer Ozurdex. So in terms of prophylaxis against recurrence of infection for toxoplasma, this is controversial. There are 2 papers listed here, and one said it's important to give prophylaxis, and the other said really there's no difference. But you would definitely want to consider prophylaxis if it is near the macula, near the optic nerve, in a one-eyed patient, and it can take the form of Bactrim 2 tabs daily 1 week prior, and to continue as long as you're giving steroids. Antiviral therapy is important. I always give this for my patients with simplex or cytomegalovirus, in some cases of varicella zoster that are chronic and recurrent. For CMV, generally, I prefer to give topical ganciclovir, and in cases of endothelitis, oral valganciclovir. Now, we do face surgical challenges in these patients, especially those with enclosed back, in patients with ankylosing spondylitis, how to posture the patient like this when he cannot even lie flat on the pillow you provide him. So my anesthetist often is instrumental in helping me to position this patient. We stack up the pillows, and then we actually flex this portion of the operating bed so that it just meets the head so that he's supported. And then we tilt the bed in the Trendelenburg position to get the face parallel to the floor to make surgery easy. Now, we're coming now to pupil enlargement, and of course, in an iris that is not adherent to the anterior capsule, we can use medications intracamerally. We can use 1 in 100,000 adrenaline, right, intracamerally. We can use 0.5 1 in 1,000 epinephrine in 500 ml of BSS in your irrigating infusion to keep it dilated. You can also give preservative-free lignocaine that will also help. There are newer medications, and this is far more costly. There are commercially available Midraine that's given intracamerally, and Omidria, which is given in the irrigating solution to maintain the dilation. However, if you do have a patient where the pupil is stuck, it's not so easy to use these medications. So I'm going to show you now a patient who has got a small pupil, and this is really also an intermittent lens. The pupil I thought was not really that small, so I had actually aspirated some of the lens material, swept the swollen cortex towards the center to flatten the mid-periphery, and then continue it tearing outwards. And you can see this patient had polyarthritis nodosa, and because of that he has vasculitis and involvement of the iris, and so he actually is having an Marvin syndrome, which you can see here, right? The iris is really floppy, and as I proceed with the surgery, you can see it's getting smaller and smaller, and so it's important in these cases to keep your phaco parameters low, your flow not too high, and also your bottle not too high, and to maintain your phaco tip in the center, and to do all cupping techniques rather than sculpting so that you do not have the risk of aspirating the iris. You can retrofunction syndrome as you enter with infusion. Again, the pupil comes back to a small size after your infusion is removed. So when we inject the IOL, it's important to make sure that you inject this into the capsular bag and not the sulcus. So you want to inflate just the capsular bag, all right? And once you have that inside the bag, we want to remove all the OVD. This is another patient where the pupil actually is not well dilated, but it can be dilated further just by injecting the BSS with adrenaline, and then just some OVD injection and sweeping of the iris to release the adhesion. Of course, you might want to enlarge this further. Now, we can also enlarge the pupil further, as we said, retentive viscoelastic, especially viscoadaptive, like Helon 5, that's able to bulldoze open that pupil and keep it there as long as your flow actually is high. You want to remove any pupillary membranes that are present, and if there's posterior synechia, you can use a Coben hook, which is a push and pull instrument that can release synechia very conveniently, 360 degrees. And then you can stretch the pupil, but you want to avoid stretching if the iris begins to rip because it's atrophic and it's not stretchable. All right, so in an iris that is non-stretchable, what you do then is to do limited sphincterotomies. And I just want to remind you the anatomy. You want to cut only the sphincter pupillae, and sphincter pupillae is just these few mm around the pupil. So you cut 1 to 2 mm all around or in the area where it is not expanding. If there's peripheral anterior synechia, always release this before you release posterior synechia. So patient here has a complete pupillary membrane, and how to pick it up without injuring the capsule. I pick it up over the iris first. I lift it off the capsule. And once you've lifted it off the capsule, you can then pick the membrane. And this is using capsulorhexis forceps. This happens to be a Kawai forceps made by Asico. And you can just pick this up and then do a capsulorhexis maneuver to remove the membrane. Well, you can also cut it at the end, right, so that it gives you a nice pupil, and then you can expand that further with iris hooks. Now, if you have a partial membrane, it is easy. You just sweep from the area with no membrane to the area of membrane, and you lift up the iris, and then you use a coupling hook, which, as I said, is a push-pull instrument that can remove the syncytia all around, and then you can remove the membrane to make a really nice, well-dilated round pupil. Now, this patient here, this patient has a white cataract, so I want to stain the capsule, and to do this effectively, I am actually inserting iris hooks, right, in the presence of BSS. Now, if you do find that the anterior chamber collapses, you can inject air straight away. All right, so you don't have to fill this with viscoelastic, and then you can have a very effective staining of the anterior capsule after injection of the air bubble because there's no OVD in the eye. Right. After this, you can proceed with aspiration of the cortical material and your capsular axis. Now, this patient here, you can see this patient has got peripheral anterior syncytia, and the way I do it to release it is just to push. Right? You don't have to inject viscoelastic. You just push on the syncytia, all right, from the corneal edge where it's attached towards the angle. And once you have relieved it, you then go and attend to the posterior syncytia, which you now release, all right? And again, you watch for the rip. Now, if it does not come easily, you want to actually provide the counterforce, and you can see a second instrument here providing the counterforce, because if you pull too hard and it does not come, you can actually tear the root of the iris and cause phenomenal bleeding, right? So you provide the counterforce, and then you tear the membrane off the pupil edge, right? So this is a patient who has sarcoidosis with huge granulomas that have now resolved, and we're trying to open up this pupil that's rather atrophic and does not stretch easily. And after that, you can put in the iris hooks and complete your surgery. Now, this is a usable tool, very good for patients who cannot afford hooks nor afford iris expanders. Right, this is the Bilo pupil dilator. You can have it coming with 2 prongs or 3 prongs and through different incision sizes. And you want to put some viscoelastic under the iris as you manipulate these hooks onto the pupil edge. And when you actuate it, you keep it there for a while to expand the pupil, and then you walk it out of the eye carefully. And you can see that this does expand the pupil very evenly and beautifully, and you do not need additional devices. Now, this is a patient with a bit of a pupil membrane here, which is actually quite easily removed. It's not so adherent, so I'm using the capsular axis forceps after releasing it with some OVD. And then at this stage, we're going to expand it a little more. And this is using the second version of Malugin ring. All right, this goes through a 2 mm incision. It's made of 5O proline. And you want to make sure that you loop it on properly, that these scrolls actually latch on and do not slip under. And when you want to remove it, you retract it and compress those 2 scrolls as they come out. Right, so the 2.0 version, the newer version, is really much easier to remove because the scrolls are not so tightly bound, and it comes in a 6.25 and a 7 mm expansion ring. Of course, for uveitis, we use the smaller one. Now, this patient, as you can see, has got band keratopathy and no pupil, which I picked up. You can see the iris also is rather atrophic. So I'm very careful when I do this maneuver. I do not want to cause any bleeding at the outstart. And here again, we're going to use the Malugin ring, retract it, put some OVD under the iris that gets the scroll under immediately. Sometimes in a very small pupil, it can be very difficult to get it on all at one go. So you can see it doesn't matter if you have just one scroll there. I like to use the coupling hook to stretch the iris rather than to push the ring to the angle opposite. And you can then walk the scrolls on one by one, and you can see because of the band keratopathy in this 90-year-old man who didn't want to have any corneal surgery, we are using the endoilluminator, which I learned from Amar, just to illuminate the nucleus to enable us to safely remove this cataract, because the band keratopathy causes light scattering of the microscope light. And at the end of this, again, we retract. I like to retract the initial scroll. There are many ways of doing this, and then release the final scroll. And then this patient was happy because his windows the pupil, the iris was really shut for many years. So you can see here this patient who had a successful phaco. Now at the end of the IOL insertion, we notice that the capsular rexus is too small. It's important to enlarge this after making a little snip in the rexus and then doing that maneuver all around to prevent capsular phimosis. And you can see the triamcinolone being injected at the end of surgery. This is a patient who developed capsular phimosis at 1 month. This was done by a colleague who was not familiar with managing uveitis. And you can see that there's a lot of fibrosis just at 1 month that has developed and has brought the vision down to counting fingers after initial good vision over the first couple of days after surgery. And this membrane is actually within the capsular bag. I'm pulling it and dissecting it off from under the anterior capsule. And you can see that we can remove it actually completely. It's more difficult to do when it's several months after the surgery, and sometimes you may end up tearing the capsule, so it's better to do this early, intervene early. And of course, we want to make sure that the zonules, which are probably weak in this case, are actually supported. And then after the capsular tension ring has been inserted, we then enlarge the capsular rexus and remove the fibrotic areas that remain so that it does not actually recur. And this patient was very happy to have her vision restored immediately after surgery. So this is the pediatric case and has developed peripheral anterior synechiae. This patient with juvenile idiopathic arthritis, and you can see the synechiae here. And my glaucoma colleague had been in already in this eye to do a goniotomy. And here you can see the synechiae being released just with a sweeping of the viscoelastic cannula and then removing it with the forceps, right? So I'm sitting temporally and I have incision superiorly and one temporally. So I can go in from either incision. And then I'm going to put hooks because this is a small eye in a shallow anterior chamber. So definitely not a Malugian ring in shallow chambers or pediatric cases where everything is small. We then do the capsular rexus, right, with the Utrata forceps, and you can switch hands, right, in order to get the right size in the right shape. And then the OVD is removed. And because this patient is only 6, I generally would open up the posterior capsule of the inject a bit of dispersive viscoelastic, and I would do this until the patient is 8 years old, right? Anything more than 8, probably the child will be able to cooperate with a YET capsulotomy at that YET laser machine. So after doing a limited vitrectomy, dissociated vitrectomy, we then inject the LL, and if you are worried that it goes into the posterior capsule opening, you can put it into the sulcus and then manipulate it into the capsular bag. And after removing viscoelastic, we make sure that this is fully sealed. Right, this is another patient that wants femtocapsilotomy. So this patient has actually got a membrane which we are removing now, and then we're expanding the pupil with a Malugian ring. This is the version 1. You can see it is made with 4-O-proline and much more sturdy. And I really like the 4-O, although it doesn't go through a 2, but a 2.2 mm incision. So I want to use this cohesive viscoelastic in this step so I can completely remove the OVD, and then I put a stitch. This is using a Zimmer laser, femtosecond laser, because I don't have to shift the patient. It's in the OR, and then after the laser, I stain with trypan blue to ensure that this is completely cut. Sometimes it's not complete, and that's why we want to put the settings for capsulotomy and for fragmentation to the maximum. And then after gentle hydrodissection, you can see that the pieces are indeed nicely cut, and we can remove it with great ease and inject the IOL into the bag, and then finally remove this with the help of the injector. So you can see this is actually me with the laser in the same OR. Right, so sometimes we do have pupils that are very small, but at other times, less commonly, we may have a big pupil that is really no good for the patient. So this patient had a single episode of herpes zoster ophthalmicus and developed diffuse iris atrophy and a permanently dilated pupil like this. and wanted some treatment during his cataract surgery. So after staining the capsule, we create a capsulotomy. It's just shy of the 6 mm, inject a capsule tension ring. So this is done routinely when we want to put in an artificial iris. So after the IOL has gone in, we then take out the artificial iris, and this is without fiber because we're not going to suture it. We then refine to 9.5 mm for a standard eye and 10 mm for a myopic eye to fit into the capsular bag. You can fold it or you can inject it. If you fold it, it will go through something like a 3 mm incision. If you inject it, it can go through a 2.4 mm incision with a Medicell AccuJet injector. You want to hold it at the pupil edge while you retrieve your Kelman forceps and then gently ease it into the capsular bag. Staining the capsule helps visualization, especially when you have a dark iris like this, to ensure it goes into the capsular bag. Right. If you do have a toric lens, I always remove OVD first before injecting the iris because I want to remove it from behind the IOL. And we can see in this case here, this patient was very happy. Although you look closely, yes, it looks a bit strange, but from a distance, it looks quite normal, and this patient no longer has any glare. So post-operative management is absolutely important. In these patients, you want to give intensive topical and oral steroids when necessary, and topical NSAIDs should be continued. You want to monitor the patient's inflammation and where possible with the laser flare meter. And if you have a OCT, please do always monitor the macula for swelling. And you want to treat any of these complications aggressively, especially if there's fibrin, posterior synechiae, recurrence of inflammation, or hypotony. And that I'm just showing you a patient that actually developed hypotony, and that's why I'm injecting Ozurdex. And this can be done in the clinic, and it can be quite difficult when the eye is hypotenuse. And what you do is really use a cotton bud, like what you see there, to actually indent the eye so that the eye becomes a little more firm when you introduce the needle. So in conclusion, pre- and post-operative control of inflammation is crucial to achieving a good visual outcome in uveitic eyes, and you want to avoid IOL in poorly controlled eyes. If you follow these guidelines that I've laid out here, I think you will have good outcomes in your patients. Thank you very much.
Thank you so much, Professor Chi. I think wonderful elaboration of uveitic cataract, and we couldn't have had anyone better than you to tell us about it. And now I would call upon none other than Padam Shri Professor Lahane. I'm very proud that he comes from Marathwada, to which I also belong, and he's going to talk about the Marathwada cataract only. So which is a very difficult cataract to handle and which we get a lot of in our area. Welcome, Dr. Lahane.
Thank you, madam. Madam is my guru. She has taught me, and I am very much proud that I am her student and she is my guru. So I am sharing the screen. What is happening? Why I am not getting my screen?
Dr. Lahane, go to share screen first, then go to your presentation, and
But
again,
I have gone to the say, but the Zoom is showing. I think
where is your presentation?
it is on my, but this is coming as a Zoom here.
It's okay. You can go back again and do share screen.
Okay, I will have to go to
Go back again.
Okay, then share the screen.
Yes.
Now here it is coming share.
Ah,
So I will have to say what? Share this, share na?
the green one at the bottom. The green button.
No, but here it
Yes,
is Zoom
you
is
share,
coming.
but you need to go on
Sir, Dr. Lahane sir,
Huh.
sir, sir, open the PowerPoint presentation that you want to show. Right now, you can stop sharing. Sharing करणं तुम्ही stop करा.
Huh.
आता तुमचा जो व्हिडिओ, तुमचा जो तुम्हाला PowerPoint दाखवायचा तो ओपन करा तुमच्या कॉम्प्युटरवरती.
नाही पण हे मला हे तुमचं बंद करावं लागेल मग.
नाही बंद सर ते हवं म्हणजे त्याला एक इथे छोटं बटन आहे, त्यांनी पूर्ण मिनिमाइज होत नाही पण थोडं कमी होतं ते, थोडं शॉर्ट छोटं होतं. आणि मग त्यानंतर तुमचं प्रेझेंटेशन तुम्ही ओपन करून ठेवा स्क्रीनवरती.
ओके एक मिनिट. MOS हार्ड कट.
Athar, can you help, please?
Hmm.
Or Rahul? Dr. Lahane, as Vardhan said, आपका PowerPoint presentation desktop पे रखो, so it is easy for you to.
डेस्कटॉप पे आया है अभी.
सर ओपन केलं ना त्याला.
हाँ.
Now come back to Zoom.
Now come back to Zoom. Yes.
आणि share screen, sir. Now you will get that option.
झूम कुठे होता?
You are on Zoom. Now share screen.
मिनिमाइज झालंय ते.
उजवीकडे मिनिमाइज झाला असेल सर मोस्टली. उजवीकडे कोपऱ्यामध्ये मिनिमाइज झाला असेल. स्क्रीन.
You can bring it to the left of your desktop to make it easier for you.
सर तो पॉवर पॉइंट मिनिमाइज करून फक्त एक बघा झूम ची कुठे आहे. पॉवर पॉइंट फक्त मिनिमाइज करून झूम कुठे दिसतो तो एकदा लोकेट करता येईल तुम्हाला.
हा इथे झूम दिसतो पण तो येत नाहीये.
येत नाहीये.
हा एक मिनिट मी पुन्हा जॉईन होतो थांबता.
ओके.
समथिंग इज गॉन रॉंग.
I think Sumit is going to help you. Sumit help करणार आहे.
Sumit is coming. Sumit will help you.
In the meantime, then shall we go on to Ragini's presentation?
रागिनीचा प्रेझेंटेशन पण माझ्याकडेच आहे.
Oh, okay.
Okay.
Okay. Ragini has joined from her phone, I think.
हा.
Okay.
ओके. तिचं प्रेझेंटेशन माझ्याकडचं इथं आहे. तुम्ही सगळे मला दिसताय. हा आता मला माझं प्रेझेंटेशन सुरू करतो. काय झालं रे?
I think Sumit has come.
माझं प्रेझेंटेशन इथं याला मोठं कर. काय नाही. कशाला एवढं करतो?
Visible mode?
आता हे हा हॅलो कॅन यू सी?
No. No.
No, not it, sir.
No.
सर हा आता बघ.
With the share कर. Now we can see. Yes. Perfect.
ओके दम लागला बस.
Sure.
हॅलो नाही ही रॅन माय सन रॅन सो दॅट आय कुड सी दिस. ओके सॉरी. Thank you, madam. Thank you, everybody. I think you can see my screen now. Okay.
Yes.
Whenever you go to the Marathoda Cataract, as madam has told us, there are so many challenges, and those challenges are, you can say, the capsule cannot be seen, no glow for the rhexis, weak zonular support, then more endothelial damage, difficult trenching, and risk of the PC tear. Then we'll have to go for the strategies, and the strategies is I like to plan the strategies whenever we are doing anything. Then I will have to plan the strategies like that. I plan the cataract, so the dye assisted rhexis, and in that, see, this is the dye that I am doing the rhexis. You see in the Marathoda, normally the cataract is a very hard cataract because there is no rain in Marathoda, and because of that you get the black cataract sometimes very. See, this is also a white cataract, which is see, I am doing the rhexis, and this rhexis you can see here. This is the dye assisted rhexis. So in the dye assisted rhexis, so in any hard cataract, because we can't see the capsule, so we go for the dye assisted rhexis, and then the see the generous use of the visco as a epinucleus plate is absent here. Leathery fibers should be completely separated, which are there in the posterior part. Use of the hyperburst and burst more. See here now, I am just, you can see the color of the cataract, and this is the I am doing the rhexis, and you can see now whenever I am going here, burst, and see now the separation. If you see the posterior fibers, I want you to see properly here again, and then rotate and go from the other side also. See now here the fibers are seen, and these fibers are again separated. Make two separate halves. Once you make it two separate, then then I think here you are separated, and after that now you can again, you'll have to make again 2 pieces from that. So again you will have to chop not only 4 pieces, but you will have to chop the more pieces also. Now here you will see I have separated it, the half of the portion, and then again I am rotating it 90 degree to my phaco tip. Here you will see the chopping. I am chopping to the 2 pieces, and once I chop 2 pieces, I separate it. See here, again it is very difficult. You will have to separate totally 2 pieces, otherwise the edge of the other will enter inside and that will tear, and we will think why there is a piece tear. But that is because of the edge of the hard piece which was there, and some fibers were attached to that. So leathery fibers should be separated, and once those are separated, then there should not be any problem. Here, see here now the can see the cataract. Then now I am separating it, and this now the viscoelastic substance here we use it because during the surgery, so retentive viscoelastic, that is a dispersive, that acts as a soft shell technique, or viscoelastic as a vault at the end of the phacoemulsification. If one piece remains behind, we can use that visco so that we can lift the piece and then we can remove. So, and as we use this viscoelastic, pre-op and post-op endothelial damage is less. But see, not from the other risk. This never helps you from the other risk. So here hard cataract, you can see the, now here you will see this is the Marathoda cataract, and once you are going for the Marathoda cataract, see here, I am doing the rhexis, and once this rhexis I am doing the, see here, trains, I go for the trains here, and once you go for the trains, you'll see because the chopping in such cases of cataract, which is a brown, you can see cataract, or here it is in the rubra type cataract. So in that, I'm making the trains, and this should be up to the in the center like this, so that see I'm going in. It's like a burst and hyperburst and pulse modes are used, and once that is used, see here again I'm going in, and after making the train, see now the burst, see here the separated. So once I separate, again you see in the slow motion, see here you have to go and separate it up to the center of the nucleus, and once you separate it up to the center of the nucleus, the fibers, leathery fibers are there, and these leathery fibers, those are very, very elastic, and you have to separate it. So this I am separating here, and once I separate these fibers, then again see now, separate till you see the red glow. That is very important. Once you see the red glow, then you again rotate, and once you rotate here, you see I am doing it on the other side. Again I will separate it, and basically here you will have to make the 2 halves of this nucleus, and when you make the 2 halves, then only it is possible so that you can rotate and remove the remaining nucleus here. And if it is not separated, then it is very difficult to operate. Now you see the case 2. You see here I am operating, and can you see the black cataract? Now this black cataract, you see always these are the patients which are coming from the Marathoda, basically from the Latu. So these cases here you will see I am separating, and the posterior fibers are very, very important to be separated, and make a 2 separate halves of this nucleus. Now here you will see again I am separating here, and you will see the leathery fibers are so elastic, you can say those are rubbery fibers, and then I will just making now the chopping. Here you can see the whenever I am chopping here, again by the other half of the nucleus go inside, and it should be slightly below to the, you can see in the center of this nucleus, go and separate. Now once this is separated, again I bring the piece here, you can see here it is a black in color, and you will have to, it's a hard cataract. I'm separating it, and you can see on both the sides. Now the such last fragment, you can save the power by making it small. So Whenever there is a large fragment, the 4 pieces are made. Out of that, we can make 8 pieces. Whenever use the chopper, make small pieces so that we can save the power. And so power is less, then we can also save the endothelial damage. Here you can save this. And the last piece, as I was telling, the last piece you will have to go for the visco, and then you can go. Now see these muscles. The technologies have developed much more than the basic today. Can technology help? Yes. Phaco mode, you can see the continuous mode you can use. Then you can use the pulse mode, burst mode, or the single versus multiple. This. And see whenever, now this is the, see here on the torsional. This is outside the eye. You can see torsional how it works, and longitudinal and torsional together how it works. So this is what happens whenever it is going to happen inside the eye. Just I am showing you the outside picture, that how torsional works and how the longitudinal torsional together works. Then see now here, the both nucleus you will see. In the one side you will see I am just using the longitudinal, and in the this torsional, and the right side I am using both longitudinal and torsional. So it is called as an intelligent phaco. What is intelligent phaco? Now now see here, the whenever it is required, the longitudinal phaco also start working. See here I am touching on the right side, you can see, and on the left side you can see near about slight can see on the nucleus. Both nucleus are similar, quite similar. Here you will see the nucleus is separated in the where I am using both. That is the torsional and longitudinal. You can see in between the longitudinal phaco is also used, and here again you will see the I have separated the nucleus on my right side. That is where I am using both techniques together. That is the longitudinal and the torsional. And in the left side I am using just the torsional, and you can say I am struggling there, and the struggle is continued. Yes, I am separating there also, but here you will see now I have removed near about half of the nucleus on the when I am using both together. So there is no any financial interest in that, but yes, the longitudinal and torsional, it works better than only one torsional phaco. And you will see this in the right side. I have completed the phacoemulsification. Now here again I will show you few cases, and in this now see this is the again you can see there is a can see the calcified area in the capsule, fibrosis of the capsule, and I am doing the rhexis here. Now when I am doing the rhexis here, you can see this is the blue rex. I am using the dye-assisted rhexis and the fibrous area. So in this fibrosis we don't know how much area is fibrous and what is not fibrous, and so it is going in the periphery now. Now once it is going in the periphery, then again I am using the forceps, and this forceps also you will have to use properly. Otherwise again the fibrosis, if it is there, it goes in the periphery, and then you will have to again see. Now I am trying. Here you will see again, but again because of fibrosis it has gone in the periphery. But yes, I could do the rhexis, and now this is the already the nucleus. It has came in the anterior chamber. Now here in such cases there is no support, so I am doing the vertical nucleus, easy for the horizontal chop here. So I am doing the horizontal chop. Can see this horizontal chop. Again you will see my chopper. It is a not sharp chopper, but it is a blunt at the tip. So this chopper I am using, and the separating the pieces, and also can see the nucleus. It is moving because no support behind. And here again I am chopping, and this chopper here, the one piece remain. Again you will have to support here, and if possible go for the minimal chopper maneuver in the last piece. Otherwise this may give rise the surge. And see here the chopper is not moving. The tip is in the center. Tip is also not moving, and gradually every nucleus is coming here, and completed the case. This is the other case You can see this is an hypermature cataract, and as you know, the such cases are seen in Marathwada because they come very late. Now here again you will see I am doing the also dye assisted rexis, and you will see the fluid is coming out of that. I am trying to do it by the needle. Again here you will see it is going in the periphery. You see this because of the fibrosis. I am trying to do the rexis here, and I think again now I have used the foreship and I have completed the rexis with the foreship. So you can see now here the nucleus inside is in yellowish in color. It is not in white. White was because of the liquefaction of this cortex. See now here I am doing the rexis. This apna phaco, and in the phaco you can see it is an hard nucleus. So the chopping, yes, you can see here I am trying to chop, but it is see here made up one piece. But again you can see whenever I am making the other piece, I am doing it excessive rotation of nucleus due to the absent cortical support. So here again the nucleus is rotating. So I am doing the horizontal chop, but not from the periphery, but here you can see again I am doing the horizontal. You will have to, because there is no support. So every time you will have to catch the nucleus twice, and after that you can make the pieces. Again I am rotating this, and once I rotate, see here again the slips from this one phaco tip, because this is a non-supported nucleus here, and once I have made the pieces, then gradually you can remove one by one. So this is what I removed, and here see here I have removed it, and see the last piece also. Once now there is a other case, you can see here also. Now you can see the hypermature type cataract. Again the dye-assisted rexis, milky fluid occludes rexis, and managed with the cystotome. Now see here, this is the cystotome. I am aspirating it from cystotome only. So by cystotome only I am aspirating whatever the liquid this fluid is coming out, and then I am doing the rexis with the rexis forceps. Here again you will see the rexis forceps. I am completing the rexis. This is completed. Now as you know, there was a complete cortex was totally fluid. Here again I am doing, and you will see the nucleus is moving. Can you see this? It's coming in the center only. I am not going in periphery. So can you see this modified central horizontal chop, because the nucleus is coming in the center. So horizontal chop, but from the center. Here again see the edge of the nucleus is seen in the center, and I am making the chop from the edge of the nucleus, but in the center, horizontal chop. Can you see this? So I made the 4 pieces by chopping the nucleus, and this nucleus now 2 pieces are behind my phaco probe. I have removed that, and you can see both these pieces are removed. Now this another case I will show you. Now this is the hypermature cataract. This patient is actually from my native village. Patient came to me, and I was operating the case, the hypermature cataract. See here, the fibrosis is going in the periphery, and I did it, and then was going on well till now. Now I am doing it. It is also a machine, which is from the multinational company, high-end phaco machine, and I am doing it by the high-end phaco machine. But you will see what is happening. The tip is not going in, and because of this, now I am trying and trying. See here, the tip which is not going inside. Here again you can see. So this depends on whenever you go for the echo machine, we will have to see that this how machines are working now. See, I am trying, but it is not coming. It is because of the stroke length. Stroke length, you will have to see. Now this is just change the machine and change the phaco tip and machine also. Now after that you will see it is possible. Now see the tip is going in because of the stroke length. So stroke length is more important, and that helps in the such type of cases. And I think this is the case we have completed. Now you see here, we have done one study of the cataract. One is the NS2, NS3 and NS4. Now here 30 cases were taken together. The 90 patients. Then the second, this was the first group. The second group was again 30 other eye of the same patient, and 90, this was the second group. And then what we did is 180 eyes, and in that we used the, in one is the Centurion and in one is the Infinity machine. So there is no any financial interest, just a study. You will see the phaco power. In the first group, phaco power is 30, 300 vacuum, and 30 is the, you can say, the flow rate. Then second group 40, 435, and third group 40, 645. Here you will see main cell loss in Centurion is less than Infinity. You can see here main cell loss 76, 113, then 164, 233, and you see in the third type of cataract, the NS4, it is a 338 in the Infinity, 251 is in the Centurion. The mean phaco time, you can use the Centurion, here the Infinity, and you can see here the mean phaco time is more in the Centurion. Then the cumulative dissipated energy, here you will see it is more in the Centurion. You can see here in the graph also, it is more in the Centurion. So apart from above, is there anything like a magic? What is the magic? The magic of the experience. What is your experience? It counts, and if your experience is good, yes, that helps you. Then the experience counts. I was operating in 1998. This was the cataract, and second day I used to tell them that it is because of the ear inside, and this ear is because of that. After 8 days you can see. Then the in 2000, I was telling that yes, in 5-3 days you will see. Then 2008, 2004 and 8, and 2016. So my corneas were remaining transparent, same type of cataract, but the experience of the 18 years, that counts whenever you do the phacoemulsification. Now this is what I am doing. See here, I am using the peristaltic machine. And you see this, until now I was using the high-end machines. Here I am using the peristaltic machine. And you can see I am making the chopping. So again, the chop of this cataract here, again you will see the chopping. Made the pieces here. Again I will do the small pieces. See here chopping by the peristaltic machine. This cataract I operated in 2006. I operated this case. So I am showing the old phaco what I was doing that time in the peristaltic machine. See here. And that time the Latur cataract maximum I was doing SICS, and now I do it phaco. It is the experience, nothing more than that. So here this is the peristaltic machine what I was doing. The take home message I want to tell you, high end machine, sharp tip. So don't use the tip which is used for so many times. Then the stop and chop technique, effective use of ultrasound energy. Then the experience, learn from your and your seniors, colleagues, and mistakes from you and your colleagues. Choose what is effective in your hand. Otherwise, which is not effective, definitely don't do it. Thank you very much. Thank you, MOS. Thank you, madam. Thank you very much.
Thank you so much, Dr. Lahane. Superb management of the product. I think no one must be having as much experience of it as you do. So it was a pleasure to watch your videos. Over to you now, Ragini, for your talk.
Good evening, ma'am. Respected Ma'am Malik, she's the president of MOS and my mother-like figure, though she doesn't look like my mother at all. Respected Padma Shri Dr. Lane sir, my guru, my mentor. Thank you, Santosh, for inviting me. Dr. Sarvate, it was such a great pleasure to come and see your new hospital. Dr. Sirish, always a pleasure to eat so many things at your place. Vardhaman, not the least, for doing so much hard work. And Santosh Bhai, you have been my brother for so long. Thank you for inviting me. Thank you so much. I thank Professor Agarwal for making me the Vice President. And I'm extremely sorry, Professor Sung Chi. Sorry, I should have mentioned you earlier. Thank you so much for a wonderful presentation on uveitic cataract. So without wasting time, I start with phacoemulsification in a small pupil. I really thank Sumit for doing all this when we are away and making our presentations and making our lives so much easier. Thank you, Lane sir, for doing this for me. So phacoemulsification in a small pupil. I have no financial interest. So what is a small pupil? It can be so many reasons. It could be functional. It could be because of pseudo exfoliation. We see patients from the interior because of ours being a tropical country with such small pupils and rigid pupils and sclerosis. We've also seen patients with food habits. We operate certain type of people who eat a lot of mutton and all that, and it is so difficult to operate them with poor corneas, with absolutely non-dilating pupil. The problems are the difficult rexes because the rexes is the circle of safety within which you're going to do phacoemulsification, and the rexes becomes difficult, and if you break the rexes, you break the commitment to phaco. The complication of PC tear, and then difficulty with IOL implantation and zonular weakness which may be present in these patients. So before, whenever you see a patient, it's important to plan the surgery, examine the patient in the clinic, and at that time that this patient is not dilating, or even before starting surgery, since you're going to see the patient pre-op and that the pupil has not dilated, before preparing the trolley, you have to have everything on the standby. So use either pre-operative dilating drops or intracameral adrenaline. So there are so many, you use viscoelastic like for dilating the pupil. You can use any other dilating iris hooks or pupil expanders. We've seen so many videos. Amar Agarwal sir showed Professor Boris's pupil expander and iris hooks which are available. Sphincterotomy, the first thing I learned to do when I was learning cataracts from Lane sir, when all these things were not available, to do very, very small sphincterotomies, which are not seen later on post-operative, but which helps a rigid pupil to dilate, especially when we are at camp. And the presence of a CTR ring in case of, so CTR rings, vitrectomy standbys, a different type of IOL, these are all things which need to be kept ready in case of complications which can occur. So as you can see, this is a small pupil using the capsulotomy to just pull and push the pupil. As you can see that the one synechiae which is present has opened up and the pupil has dilated reasonably well. The capsule has been stained because, there is a very mature cataract. You can see that by dilating this pupil, there are very micro sphincter tears which can be seen. But these small tears are not big enough to cause problems later on to the patient with considering glare and everything. You can use a second instrument so that the iris doesn't get caught, and you can push aside the iris where you are doing phacoemulsification, because otherwise that iris can get caught, and it also allows the pupil to open up in that area so that you can do phacoemulsification. Now while doing phacoemulsification, the most important point is to remain in the center, because that is the thickest part of the nucleus. If the center divides, the periphery will divide automatically. So the idea is not to go fishing for the nucleus and let the pieces come to you in the center. And once the machine has a good followability, this is a reasonably soft cataract, and remaining in the center with a good vacuum, we were able to suck out all the pieces of the nucleus. A vertical chop is preferred. Excuse me. All parameters should be lower because you want a stable anterior chamber. Your fluidics have to be very, very important in these cases because you don't want the iris diaphragm to be moving, which I'll be showing in one beautiful case. And like I've already said, that it is important to do phacoemulsification in a central safe zone. Liberal use of viscoelastic protects the endothelium and it also keeps the pupil dilated. So this is another video. We've seen few cases like this today, the complicated cataract, but this is one more where you're using the capsulotomy needle. It's very, very important to first open up the pupil, to dilate the synechiae, to free the rigid pupil of any membrane which may be in the pupillary area or the posterior synechiae, and completely gently doing it so that you don't have a bleed, because these irises are very, very friable, flimsy. Because they've been inflamed, they are likely to bleed and they may tear, as we have seen in some of the videos. As you can see, the gently opening the pupil with the capsulotomy needle without using anything else has opened the pupil reasonably, and then you can do a capsulorhexis. Now this medium-sized pupil is also good enough to do phacoemulsification, because what we need to do is to remain in this central zone, and knowing that you can see a bit of the glow, that the cataract is not very, very hard and it is soft enough, so you need not see the periphery. You can divide in the center. So this is the central trench, as in the stop and chop technique. And once the center divides, now I always believe, and I was taught by Lahane sir, that this is the first division which is the most important. Once you have a good first division and your nucleus rotates, then you are halfway home. So then you remain in the center and let the pieces come to you. So you just engage or block the nucleus piece with the tip, and with the vacuum and the suction, the piece gets sucked into the phaco probe. So for this, the followability of the machine, the good vacuum, so your phacodynamics, the power that you are using, the vacuum that you are using. So it's a technique which is very, very important. You use the second instrument to chop the nuclear piece and then to aspirate it. And this is the third and the fourth piece. You are in the pupillary plane. The pupil is small. It has not dilated, but since you are in the center, you can do a good phacoemulsification. The AC maintainer, as you can see, helps the pupil to remain dilated, and you can do the surgery very well. Now it is important that your bottle height is not very low, because you need to have control over the bottle height and use the height of the bottle to the maximum to see to it that you have a stable anterior chamber. So that can be used as an advantage. You use a low vacuum phaco, and the height of the bottle can be adjusted to keep a stable anterior chamber. Okay, torsional phaco, you get a better grip, hyperpulse, hyperburst modes, and a safe zone phaco. The first thing I learned was the safe zone phaco, and not to go fishing for the pieces, which is the biggest cause of the PC tear. So this is the side port. The tunnel has been made. This is again a complicated cataract. So many cataracts like this because we've done a large volume of leprosy patients. So this pupil is very small. The endothelium definitely has been compromised because of the previous inflammation that has occurred, and the disease which is already present in the patient's eye. Synecholysis, as we've seen, is very, very important. And gently pushing and pulling the pupil without really damaging it. Since the capsulotomy needle is so tiny and so flimsy, you're not likely to create too much of pressure. Gentle hydrodissection and a central pupillary area phacoemulsification. Even with this small pupil, because the central, you can make a small trench, the axis is small, and the most important thing is that the central part of the nucleus needs to be divided. So here, as you can see, the center, there is a deep, deep trench. Once you can see the trench which is deep enough, and if you can divide the center, the periphery of the nucleus is definitely thinner in bulk, and that divides too. So that is important, very important. It can be done with a small pupil. Of course, to each his own, and for people who are using rings or hooks, it's good enough. But as you can see over here, it's very comfortable to do this. This is Dr. Lahane sir's video. I am a left-handed surgeon, but it can be done. I am also, I've got used to doing small pupil phaco, and it can be done. So it is important to be a little patient, to do a central zone phaco, to divide into first two divisions and the third and the fourth. Use the chopper. You can use a blunt chopper to look under the iris and to see to it that the pieces come to you without manipulating too much and not moving here and there. Post this phacoemulsification, we always use a AC maintainer to remove the pieces of the cortex, as you can see. So as you can see that the phaco probe does not move. It is in the center, but the aspiration is used effectively to allow these pieces of epinucleus, which are being fed by the chopper, which is a blunt chopper, into the phaco probe, and it can be removed very effectively. This is a small pupil where staining has been done in order to do a good capsular access, because the cataract is quite advanced. And then, like you wait for some time before you can remove the dye so that the capsule is stained very well. And this is the removal of the dye, as we can all see. As we can see over here, the pupil is very, very small. The capsular access has been done. We come across such rigid pupils because, these are the patients who have a lot of iris atrophy because they have systemic diseases. 80% of the people who come to us in JJ are deceased with high lipid profiles, with heart disease, everybody with existing arteriosclerosis, hypertension and diabetes. And that is the reason why you have such type of pupils. So again, I would insist on a safe zone phacoemulsification to help. So, the second instrument, the chopper, is used to so much advantage to help us to do a good phacoemulsification and to protect the iris being caught into the phacotip. Once the iris get caught into the phacotip and you get chafed, then it's very difficult. It keeps coming with the flow of the fluid inside the phacoemulsification probe. As you can see, this is the the fibrosis which was present over there. So as you can see, the pupil is very, very well dilated over here. This is some part of the capsule is calcified. And what happens is, this idea is not to show a dilated pupil, but the problem with the iris diaphragm, because here it is seen so well, and that is what happens. So here it's a very beautifully dilated pupil. You feel you are very happy, and the phaco is not engaging the probe is not engaging the nucleus because your suction is not enough. And as you can see over here, this is a dancing iris. So the anterior chamber is not stable. As you can see, the pupil constricts and dilates, constricts and dilates. This instability is going to create a lot of trouble, and this should warn you to change the parameters of whatever you are doing. This is not a small pupil phaco, but as you can see here so clearly, the pupil goes down half the size, and then it becomes so difficult. It's such a jumping pupil. What's going to happen is that you are going to end up catching something which you are not supposed to do, either the iris, you are damaging the endothelium, you can have a PC tear. So this needs to be corrected. So you reduce the bottle height. You want a stable anterior chamber and can do phacoemulsification safely. So these are danger signs which need to be taken care of. The AC maintainer can be used. And your rexes may be very, very small, and that may be causing problems. So you need to have a proper size rexes, or you can stop the case and correct the rexes in between. So it's always better to to review ourselves and find out where we are, what we do before going ahead with a case. So iris can complicate it, even a soft, simple cataract. Pre-operative evaluation, checking pupillary dilatation is very, very important to plan for surgery. So all patients need to undergo a dilated examination before surgery. Early diagnosis is in retropulsion prevents further complications. Iris, it's important to manage the iris very well, because if you don't manage the iris very well, the next day, if they have an atonic pupil or an iris, the patient is going to have inflammation, a glare for life, and a bad cosmesis. Thank you so much. Thank you, Lane sir. Thank you, ma'am. Thank you, everybody.
Thank you so much, Ragini. Nice elaboration of how to deal with a small pupil. So we have had wonderful talks from the post-Alberts. Now I would request Dr. Jayant Sarvate to give his own small talk, which will be followed by Shirish's, and then we are open for discussion. Please go ahead, Dr. Sarvate.
Yeah. Here again, I'm again out of this meeting, it seems.
No, you're very much in it.
No, I know, but I'm not able to share again the same thing which Dr.
Go to the bottom.
Yeah, share screen
No, you're not doing. It hasn't happened.
Yeah, but it is not.
Otherwise, you'll be able to see your screen. I hope you have kept your, yes, now you've started. Now you have started.
Yes.
Now take your
Yeah.
presentation.
Okay.
Now click on your presentation.
Yeah.
Perfect. Yes.
I thought it just again stopped doing the thing. So,
You can just make it full screen.
thank you, everybody. I mean, after those wonderful talks, I will be sharing my views on management of posterior capsular rupture. In PCR, posterior capsular rupture can be a pre-existing disease because of the congenital problem like posterior cataract, or it can be traumatic, it can be spontaneous, and most of the times it is intraoperative or iatrogenic done by us. Its occurrence depends upon various predisposing factors. There are many factors like disoriented patient moving his head inadvertently, then an inexperienced surgeon, a learning curve of a resident, and a high volume cataract surgery is likely to have more PCR, not in the hands of experts, but in the hands of inexpert people and surgeons. And the deep set eye, a prominent brow, a poor visibility because of corneal opacity, pterygium, or a band keratopathy. Intraoperative risks include a small rexis and the rexis going bad and having a radial tear, and fluidics, as Dr. Lahane sir told us about good fluidics. The fluid imbalance can cause this type of PCR. And there is a small pupil intraoperatively, or maybe because of the synechia, and high shallow AC, as well as in case of high myotic cataracts and excessive AC depth, and post-pass vitrectomy also, high AC depth can cause this type of PCR. Pseudo exfoliation cataract, a dense asteroid hyalosis, and as Lahane sir rightly said, that unfamiliar machine, the earlier machines and higher end machines also can malfunction. My Centurion once malfunctioned, and it did have problem, but not PCR, but other problems. So these can be other issues which we have to look for. What are the signs of PCR? Sudden deepening of anterior chamber with a momentary pupillary dilatation, sudden transient appearance of a bright red reflex peripherally, apparent inability to rotate a previously mobile nucleus. That's a very important and small subtle signs which warn us of some bad omen. And an important sign of anterior capsular flap motility sign, which has been described by Dr. Rohit Om Prakash, very ably, and this can give you an early indication of PCR. Excessive tipping of one pole of the nucleus, if the PCR is large and it has been done in the early stage, and the partial descent of the nucleus if the PCR is large. So what is the flap motility sign? It's early diagnostic sign, and inverted and fluttering flaps of the anterior capsule. These indicate that the tear has not gone posteriorly beyond equator. But the inverted and non-fluttering flaps, these indicate that the tear has already gone to the posterior capsule, and you may have to face a posterior capsular tear. So these are the very important signs and early signs which we have to be careful of. Now, how to manage these predisposing factors? Prevention is better to be safer, on the safer side, and if we get this intumescent cataracts, and if the rhexis starts going bad, and at one stage when it is going peripherally, I have started cutting it with the micro scissors and then completing it slowly, so that one can complete a phaco in this situation. Another sign is Argentinian flag sign. This is another problem which can occur in this intumescent cataracts. If you are sure that this has not gone posteriorly, one can complete it with the intracapsular, small forceps, and one can complete the rhexis and complete phaco if it is possible. Another factor is hydroresection. Gentle hydroresection is a key to a good phacoemulsification, as we have been taught earlier. A slow hydroresection in a proper plane is very important to have a good phacoemulsification in the later half. But if we do it in a haphazard fashion and inadvertently the plane is wrong, see what has happened. This has given way, and the nucleus has been popping inside, as well as there is a vitreous presentation. The managing the pupil, poorly dilating pupil. Well, this portion I will leave with Dr. Shri, because he is also showing these videos, so I will skip these videos. And some of the factors Professor Rajani Parekh Madam also has told you. But this is an important step to prevent PCR, because the small pupils can be very problematic and can cause PCR very easily. Now we come to the PCR during a phaco. We have done a good phaco, and the last piece is being chewed. We are happy that we have done everything, and see what has happened. The last piece, this is a typical time that the PCR happens and the vitreous is popping inside. Now we have to fill the anterior chamber with high viscosity OVD. And we can do a slow and very systematic removal of this eye, and if this vitreous comes into this, you have to mechanically separate and do a vitrectomy. Now I want to talk something about the vitrectomy part. We are filling this with a high viscosity OVD, and now we tend to do an anterior vitrectomy from anterior side. But it is always mentioned that it is better to do this anterior vitrectomy from pars plana route, because the vitreous is not, doesn't pop inside the eye, inside the anterior chamber, but it comes back and regresses, so that the PCR is not extended. So this is the correct way of doing vitrectomy. And now 3-piece IOL is injected on the anterior capsular axis after the proper vitrectomy has been done. One can do a reverse capture of the optic if we want to be sure about this centration. We have to do a suturing of this incision to avoid any leak, as well as the vitrectomy incision also is to be sutured. Another thing is PCR. Now we have done everything. We are doing. We have done the good phaco. Everything is okay, and now we are injecting the lens. The 3-piece lens is being injected. See what happens. Now what happens is the first haptic has gone inside, but the second while implanting the second haptic, it has been pushed so hard that it has been causing a PCR which is inadvertent. But as the one of the haptic is in front of the capsular axis, the lens is pulled out of the bag. The haptic is pulled out of the bag, and it is centered in front of the anterior capsular axis. Now, managing the PCR in posterior polar cataract. Here I am purposely giving a video of Dr. Deepak Megur, because it indicates each and every step of what to be done and what not to be done in such a complicated situation. And I'm very thankful for allowing me for giving this video in this presentation. This is a classical posterior polar cataract. And what happens is here the most important form is we do not hydrodissect, and if possible don't hydrodelineate also, but one can do a hydrodelineation not up to the periphery but up to the center only in very different quadrants. Frequent use of high viscosity OVD is very important to keep the anterior chamber deep. Mechanical separation of epinucleus, and again injecting OVD all the time so that the pre-existing tear in case of a posterior polar cataract doesn't extend. A very low parameter of phaco, very low vacuum, and and again injecting OVD. This is the mantra of removing the all the material, cortical material very slowly, and the central plaque of the nucleus. See the pre-existing tear, which is very big, but at the same time there is no vitreous loss. One can achieve this a good untouched hyaloid face with a controlled phaco. This is what I wanted to depict. That is why I specifically chose this video. And slow, very slow movements of every step. Injecting OVD all the time is again very important, so that the hyaloid face is still intact, and one can do in the bag implantation of single piece IOL. And here I again want to mention one thing, that the haptics of this lens should be perpendicular to the PCR, so that the PCR doesn't get extended inadvertently later on. And very slow and gentle manipulation of haptics without dilating the haptics. That is another important piece of advice one should like to give, and this is how it is completed. And hydrocortisone to know that whether there is any vitreous in the anterior chamber. There is none, and so the job is very beautifully completed in this very complicated situation. So to summarize, we have to try to assess the situation which can potentially cause PCR and be prepared with appropriate measures. If PCR has happened accidentally, one must be calm and should not hesitate to convert to SICS if we are not sure of the extent of PCR, as in case of early PCR when the hydrodissection has gone wrong and you have caused the PCR in an early stage. So in this case, we have to convert it to the SICS rather than continuing with the phaco. If the PCR is small and vitreous is intact, one can gently finish the further procedures and implant the IOL in the back. Haptics should be kept perpendicular to the PCR site. If the PCR is associated with vitreous incarceration, then a careful anterior vitrectomy, again I stress preferably by pars plana route, is indicated. An anterior segment surgeon should be proficient in doing a pars plana with core vitrectomy. I'm not talking of posterior vitrectomy, anterior vitrectomy, to overcome any adverse situations which we can face in these complicated cases of phaco cataracts. We must be deliberately very slow, very methodical, and careful in performing every step of phaco. Thank you very much. And there is another presentation which I want to do. It's a phenocane assisted cataract surgery. This is one presentation which is very small presentation. We are talking of undilated pupils, intraoperative meiosis, and phenocane is a substance which has been given to us by Entourage Pharmaceutical. This is the combination of tropicamide, phenylephrine, and lidocaine. So as we know that adequate mydriasis before surgery is very important, and rapid onset of mydriasis is always preferred. But an intraoperative meiosis also can cause many complications like PCR, iris trauma, and further complications of increasing the chances of endophthalmitis and macular edema. So, a disadvantage of topical mydriatic drops, which we have been doing routinely, the topical mydriatics cannot be relied upon, in the sense they may not have a good mydriasis. It takes about 20 to 40 minutes, and multiple eye drops are required, and the mydriasis may not be consistent. So intracameral mydriatic injections have been used. One is an epitrate or epinephrine which has been used, but it is not used for primary dilatation. And now for stable mydriasis, a prompt onset of pupillary dilatation, these can be advantages of intracameral mydriatic injections, and significantly less pain or sensation of pressure to patient just before the IOL insertion. So Entourage Pharma has come out with atropic at 0.02%, phenylephrine HCl, phenylephrine hydrochloride at 0.31%, and lidocaine 1% in 1 ml presentation, which is DCGI approved, preservative-free drop, and shelf life is 24 months with a room temperature. We can store it at room temperature without refrigerating it. It has been shown by some randomized control studies that 95% of the pupil dilation was achieved within 20 to 28 seconds after administration of intracameral injection of lidocaine. It dilated to about 6 to 7 millimeters, and intraoperative pupil diameter also remained stable till the end of the surgery. And there was no significant change in pupil diameter in between the surgery. So this, if I compare clinically with an adrenaline injection of 0.1%, 1 milligram per ml, it has got some disadvantages in form of it is contraindicated in hypertensive and IHD patients, ischemic heart disease patients, and there is a moderate dilatation of pupil in case of intraoperative meiosis, and we have never used it as a primary dilator without using any dilating drops. So this phenocane combination, because of this unique combination of drugs, achieves pupillary dilatation of 6 to 7 millimeters and appears to be a safe alternative, though more studies are necessary to prove its safety in compromised situations. I will share some of the videos. This is the primary cataract without dilating. A topical under topical, I have injected phenocane, and the pupil has started dilating within seconds, and about 6 to 7 millimeters dilatation has been achieved till end, and the end result at the time of ending the surgery is still dilated pupil. Another case is intraoperative meiosis. Here I have completed half the phaco, but the pupil has started reducing in size, and now I am injecting phenocane. the pupil has started dilating to a comfortable level, not to a great extent, but it is a comfortably dilated pupil, so that I can complete my surgery without any problem. Another case is I have not at all completed the phaco. The pupil has already constricted. It's a hard cataract, and here again I am injecting phenocaine. Now this has given me adequate pupil without any pupillary stretching or any rings or hoops, and still most of the cataract could be removed without any problem, and till the end of surgery the pupil has remained mid dilated to my great satisfaction. Okay, so this is the end result, and this is how I find that this is a good adjunct to our phaco surgery. Thank you.
Thank you so much, Dr. Sarate. Now, Shirish, please start sharing your screen.
Yeah.
And Dr. Sarate finishes.
Yeah.
Stop sharing the screen. And can I please request you to keep the talk?
Yes.
Yeah.
I'm sorry to have to say that to you. Generally, it's the last speaker who gets the
Yes,
bad
yes. Shall I start?
Yes, please.
Yeah, please.
Go ahead, go ahead.
Is it visible, madam?
Yes.
At outset, let me thank President Dr. Malik madam and Secretary Vardhaman sir for giving me this opportunity. Special thanks to Dr. Santosh Bhide for coordinating and leading the webinar. Friends, every phaco surgeon must know how to manage the luminal dehiscence, because many times it presents as a surprise on the OT table itself. Out of different causes, trauma and pseudo exfoliation you are encountering day-to-day life. Some grades of dehiscence, mild, which is less than 90 degree, can be managed with the IOL itself, but moderate degree needs some CTR implantation, and severe luminal dialysis, which is more than 120 degree, needs some scleral fixation devices. Going to the cases one by one straight away, this is a case of small pupil with slow exfoliation. I thought I will go with the phaco with this size of pupil. So staining was done, and see, stria. The wrinkling or stria is the first sign of ill wounds. So pupillary dilating devices are used. You can appreciate the phacodonesis and the stria on the capsule. So medium size is done. The rexis should be started away from the area of dialysis in general, and once it is completed, central hydrodynamic is advisable. Now it is time to insert the CTR. It should go slowly under the anterior capsule with the help of forceps. Now you can see tenting of the capsule. The tenting of the capsule indicates that it is in the back, and this is the time to support it with the other hand and take all stress on this syncytial groove and avoid stress on the zonules and guide it into the back slowly. Slow motion phaco is performed. The only difficulty in such cases is a removal of the cortex. You can see how difficult the cortex is getting removed. But the tangential movement, the tangential stripping of the cortex helps in the removal of the cortex very easily, but with patience. After removal of the cortex gently, we have planned to insert a 3-piece IOL, which is our preferred method of the technique. The cortex is getting removed completely. and 3-piece IOL is being injected into the sulcus and optic is being captured into the bag. So haptic takes support of the sulcus and bag is supported by the optic. Friends, this is another case of pseudo exfoliation where CTR is implanted at the lateral stage. You can see how the nucleus is dancing. Such cases cannot be supported by CTR alone. Hence, these flexible and non-traumatic capsular hooks were used. After supporting the back, this is a wonderful tool to have in such cases. Again, slow motion phaco is advisable. And removal of the hook and removal of the cortex is done very slowly. You can see in this case, the cortex is getting removed very easily as compared to previous case. Once cortex is removed, now it is time for inserting the CTR, which is more difficult in such cases. Insert a CTR under the back and help with the Sinski's hook, guide it very slowly in the back, like on 3-piece IOL and scleral supporting devices were used. You can insert the CTR at your comfort level, but I usually advise to use it at immediately after the capsular access. The best quote is implant CTR as late as you can, but as early as you must. Friends, 3 types of CTR are available: 10, 12, 11, 13 and 12, 14. And you can use it according to the axial length of the patient, or you can take the help of white to white. Generally, 24, 28 mm of eyeball needs 11, 13, which is most commonly used. Apart from stability, the CTR prevents the IOL decentration and minimizes capsular phimosis. But there are some limitations. We had 4 cases of whole IOL CTR and back complex getting down, dislocated into the vitreous 6 years after the surgery. You can see how the lens and all whole complex is done. So we modified our technique of sulcus fixation of the haptic and capturing of the optic in the back. These cases needed much scleral support in the form of these some popular devices. Getting straight away to the case, this is a case of Marvin Syndrome. Every step is important. Start axis away from the area of zonal dialysis, go slowly and complete toward the area of strong zones, purposefully decentered it. Slow hydro, gentle hydro is needed. Nucleus is soft, so it come out easily, and gentle I and A will do the trick. Now this empty bag is ready for the insertion of the Sioni ring. This Sioni ring has got hook and eyelet for scleral fixation. Get prepared with the 9-0 suture. Just knot it to the eyelet of the hook and start inserting. The insertion should be toward the area of the zonular dialysis. This is the most important. We should dial it to the area of the zonular dialysis. Align it with the scleral flap, and with the railroad technique of 9-0 proline and 26 number gauge needle, take out the proline suture out of the scleral wound, suture the scleral wound, tie the knot, and you can see how nicely the bag is getting fixed. Friends, the CTR and the Sioni ring have got some limitations. They cannot be used in the cases of break of anterior and posterior capsule. In this case, these capsular tension segments are helpful. The MS segments, it merges the concept of Sioni rings and capsular retractor. It can support the bag during surgery with the help of hands only, and the same segment can suture to the sclera post-operatively for motility. This is one of my favorite instruments, that is SC anchor. Has got middle limb, a short limb, a long limb, 2 holes on the middle. After SC is performed, scleral suture is passed, taken out through the corneal wound, and this wrapped around the SC anchor. This is how it can get wrapped. Or you can use a central hole for getting it fixed. Pull it inside, lower limb toward the sclera, upper limb to be inserted into the back to get back fixed, and how nicely back getting fixed. This is actual case of Ashianka, where you can find this is a boy of 7-year-old with a history of trauma. Large subluxation more than 180 degree, principally same. Start the axis away from the zonal dialysis. Patience is the key. Go slowly, go toward the area of zonal dialysis and again turn to the area of great zonules. Purposefully decentered it toward the area of strong zonules so that when you pull the bag, it will come into the center. Now hydro is done. LC anchor 2.5 by 3 millimeter, very tiny and very easy to use. Start preparing the scleral bed. Take incision 1.5 millimeter away from the sclera. Just make a small scleral tunnel for hiding the scleral sutures. Once it is done, pass 26 gauge needle from sclera below the iris and above the anterior capsule. Fit the needle in it with the nitroglycerin. Take out through the sclera. One by one, 2 needles need to be taken out. Now this is second needle taken out of the sclera. 1 millimeter apart, pulling it, getting the Asha anchor in, central rod on the anterior capsule and larger limb into the back. Tucking is slightly difficult because it is uniplanar instrument, and once you get tucked, pull the sutures and you can see how nicely back is getting pull and getting center. The rest of the case is become easy as cataract is very soft. Only iron A will do the trick. Subsequently, IOL was implanted and you can see suture is hiding and case is done. So friends, CTR at a glance, my CTR can be tackled with IOL only, but modern and severe zonal dialysis needs some support in the form of CTR or CTR or only. Yes, CTR at a glance. Last but not least, conclude proper visualization is the key. Always start axis away from the area of zonal dialysis. Leading edge of the CTR should go toward the area of dialysis, that toward the area of red reflex. Use microforceps as and when needed. Implant the CTR as late as you can, but as early as you must. Scleral groove to be taken at the center of the subluxation and use right device at right time. Thank you, friends.
Thank you so much, Dr. Shirish. That was very nice and a wonderful demonstration of all the various devices you can use for subluxated lens. I think you did a wonderful job. Maybe I have the questions now.
Yeah, I mean,
Are
ma'am,
there questions, Dr. Sadu?
Professor Cheem, are you there?
Yes, she's there. Professor Chi, can you please unmute yourself?
Can I ask a question to Ragini madam, or there are others there?
They are not there. I'm afraid all three
Or
of
the
them,
others have
Dr.
gone?
Agarwal, Dr. Amar, Ragini and Dr. Lahane.
Right. Hello, hello, Professor Cheem. Hello.
So you can ask.
So,
Can I ask you a couple of questions?
sure.
Yeah. How long do you use steroids in case of a post-uveitic cataract, and how do you taper them? One. And secondly, do you use any anti-metabolites post-operatively?
Okay, so I think it's important to treat these patients adequately. And when we say it's optimum treatment,
Okay.
it means that you need to have the patient on stable treatment
Okay.
and not stepping up treatment just to get the patient under the control at the time of surgery.
Okay.
So if you can't control the patient with oral steroids alone, it's best to refer to a doctor who does uveitis, who can help you to get the eye under control. And often this means the addition of immunosuppressive therapy. And in fact, if you talk about long-term oral steroids versus immunomodulatory therapy, actually steroids are far more dangerous because you cannot adequately monitor the side effects.
Yes.
So I would rather switch the patient, who's not easy to control, to have the uveitis easily controlled, to immunosuppressive therapy right at the outstart. And if you can maintain, that dose without having to add steroid, you can control the inflammation, then that's really good control. And if the eye is quiet for at least 3 months, then it's perfect timing to do the surgery.
And then you switch to local non-steroidal anti-inflammatory like Nepafenac or any for a longer period, along with the UVA consultant who will be monitoring the antimetabolites rather than steroids. This is how would you put it, like that?
Well, for the time of surgery, if you need to, you may add more oral steroids and then gradually taper as you watch the inflammation. It may take like 6 weeks, 2 months, but the topical steroids can be continued as long as you see inflammation in the front of the eye. And of course, I always give topical NSAIDs as long as there's no corneal melt issues. And this can be kept for longer than the duration of topical steroids. And you really need to watch the eye pressure.
Okay.
Professor Chi, is there any particular type of IOL that you would prefer in uveitic cataracts?
Okay, generally I prefer to use biocompatible in eyes with inflammation than silicone lenses. Generally, of course, we want to keep the incision small, so we do not implant PMMA lenses today. And between hydrophobic and hydrophilic acrylic, generally, if you think that the cornea may have a risk of having to undergo a DSEC where you need to put in a bubble of air, or the patient have some retinal surgery where you need to inject gas, hydrophilic lenses have a tendency to calcify with air bubbles. So definitely between the two, I in fact routinely use hydrophobic acrylic lenses.
Now, this is a question to all three of you, to Dr. Sarote, Professor Chi, and Shirish. We've dealt with hard cataracts. We've seen Dr. Lahane do that, the Marathwada cataract. Sometimes I feel it's better to have a moderate cataract, I don't mean a hard cataract, than a soft cataract, because a soft cataract is really more difficult to tackle. So
Definitely.
what is the way you deal with it? Each one of you can give your opinion.
Okay.
First of all, your opinion is right, because soft cataract was very difficult to operate, but the simple rotation and hydrodelineation, as Dr. Sarote has shown the case of polar cataract with mechanical separation of without doing hydrodissection and delineation, there are some specific choppers are available which dealt with such cases, which separate the soft cataract layer by layer, and you can have it this chopper and use for mechanical separation. And second is flip and chip technique. Flip and chip technique is the most useful key to handle these soft cataracts.
Yes, because
I would like to use a very, very old technique which we have been taught earlier, a 4-quadrant technique. 4-quadrant technique becomes very useful in these soft cataracts, not necessarily with posterior polar or any other cataract. We can very well separate it with the hydrodissection, do a 4-quadrant so that it is a very soft one, and if you do a deep trenching with the only epinucleus mode or a lower vac mode, we can suck these cataracts, soft cataracts, without using much of a phaco energy.
But Dr. Sarote, I have found when doing soft cataracts, usually what happens if you try to do the 4-way trenching, you starts getting converted into a soft shell. So then, as Shirish pointed out, sometimes it is best to flip and rotate it and then get rid of it.
Flipping also becomes easier with the 4 quadrants, because those quadrants have already been mostly separated. And it is possible to do a pre-chop of Nagahara or that also you can use and we can separate those segments, and we can have a trench also which can be deepened.
Professor Chi, anything you'd like to add to that?
No, I like to just adjust my parameters to much lower settings, and then I would actually chop without any vacuum.
Okay.
And then after that, aspirate out all the pieces, but using a linear kind of vacuum rather than a panel vacuum. So that's much safer. You can adjust the amount of vacuum you apply to it, and very, very low parameters.
Professor Chi, I have one question, another question for you. When do you use a you would like to use a femtocataract, not for a routine case, but in such tricky situations when you feel that femtocataract would be a boon rather than a normal phaco?
No, definitely, I have two very clear indications in my practice. One of them is substituted cataracts, because we know we can struggle over the capsular axis and lose more zonules. And secondly, I love to use it for posterior polar cataracts, which I know you see a lot of in India and see a lot of in Singapore. I think that having, you know, the bubble dissect out epinuclear plate that acts as a cushion to protect the posterior capsule right until the very end actually adds safety and has reduced my posterior capsule rupture rate.
And which are the segments which are available? Because this, I want to ask Shirish also about this. Where do you get that I see anchor segment? Do you have, Professor Chi, any other segments which are available, which may not be available here? Any other segments which are using segmental devices?
I think Hanita is from Hanita lenses. From Hanita lens is Israeli company.
Okay.
Yeah.
Do you use it routinely?
I use it, but not so commonly, because it just hooks onto the anterior capsule rather than supporting the equator body, which is what I would prefer really, which basically the capsular tension segment does. The only thing is that because the capsular tension segment and the
Okay, Shirish, where do you get our SE segments here in India?
Yes, yes.
Okay.
Bombay, Anita, people are providing the SE anchor as well as SE from expander also.
Okay.
And as Professor Chi has pointed out, it has got a small base toward the area of the scleral fixation, but you can use the CTR along with this thing. And beauty of this instrument is that it is very easy to use. It is very tiny, 2.5 or 3 mm only, and it is uniplanar.
Okay.
It won't come out of the anterior capsule as unity come out 0.5 mm. So there are very less chance of iris rubbing over that. So I find this is very big advantage of this instrument.
Any size of CTR you prefer, or you will choose for eyes which you are using because they are Marfans, they were maybe smaller eyes in children, you may be doing it, so you prefer to use different sizes of CTR?
Yes, sir. There are 3 types of CTR available. 10, 20, 12. That is the expansile dimension is 12, and when it is in the bag, it is 10 mm. 10, 12, 11, 13, and 12, 14.
Okay.
12, 14 is for very long eye. For 11, 13 is for general eyes, and very hypermetropic eyes, you can use a 10, 12 ring.
Professor,
Vardhaman?
I wanted to ask one question. I think this is like a lateral question to what Dr. Sarote sir had asked Professor Chi about use of femtosecond cataracts, and she said that she finds it to be very useful in posterior polar cataracts. So, Professor Chi, as we know, in posterior polar cataract, there can be a true posterior polar cataract with a dehiscence, and there can be a pseudo posterior polar cataract. So, do you also feel that the femtosecond cataract technology, because the use of OCT, also gives you an idea about whether it's a true posterior polar cataract or a pseudo posterior polar cataract on the scans, so that you can plan your surgery much better? And my second question is, how much clearance are you keeping between the cavitation bubbles and the posterior capsule in this case? Are you making any changes compared to normal cataract surgery?
Okay, so for clinically diagnosed posterior polar cataracts, we recognize onion rings, sometimes you have these riders. I would routinely do an anterior segment OCT in the clinic. And of course, with the catalyst, we have a very good OCT there, and we can also see the posterior polar opacity to see whether it's actually broken through. But you know, sometimes you think it's broken through, but it's really not. You know, you can't really be 100% sure. And I would always just look at it again when I dock them, because there may be some time lapse. And if I think that this is really posterior polar cataract, which has got a peculiar kind of irregular pattern on top and a narrow space below, and I look at the integrity of the posterior capsule, my offset would then be increased. Otherwise, I would routinely put it at 500 microns. Yeah. In fact, I've had some cases of posterior polar cataract where the air bubble went through this minute little hole into the retrolental space, all right, without rupturing. But it's a bit scary, you know, when you see this bubble that just doesn't come forward. You don't want to chase it.
Okay, I have one question for you.
Yes.
Regarding intraoperative steroids, which patient would you inject intravitreal? Which patient is suitable for intracameral and for posterior subretinal injection of triamcinolone?
Okay, so generally, if you have manipulated with the iris, and this is not an infectious uveitis, for example, cytomegalovirus anterior uveitis that we see a lot of, I would actually routinely just put in intracameral dexamethasone. This actually prevents fibrin formation, and it doesn't last for that long, probably like 24 hours. It's there. And of course, in a steroid responder, you may get a bit of a pressure spike the next day. You know, when we talk about injecting steroid to the back of the eye, basically we're considering the type of uveitis and the risk for macular edema or recurrence of inflammation. So between giving a triamcinolone injection versus a drug delivery system that gives a 3-month slow release, I much prefer the Ozurdex because it's more controlled, and also the inflammation may last for quite some time. And very often I find that in patients with I routinely would add another Ozurdex injection to make sure that the eye is well controlled for 6 months after surgery, because we know, at least from the studies I've done on VKH and cataract, actually, you know, the reason for poor outcome is actually inflammation that recurs after 6 months. And this is very often because we let down our guard and we think that, well, the patient is fine and we don't need to keep up the immunosuppression because the eye appears quiet. So for these eyes with posterior segment involvement, I like to give Ozurdex a second time and just make sure that steroids are kept up to really wipe out the inflammation.
At a later stage, you will give Ozurdex.
As well, yeah. So 2 Ozurdex over 6 months.
Okay, Professor Chi, do you have any specific strategy for pseudo exfoliation with cataract, and which may have, which may not, the zonules are weak, especially in elderly patients? Do you have a specific strategy of, say, using CT or anything? I mean, the bag to be fixed in before it tumbles down.
Okay, so I think pseudo exfoliation when they have got very weak zonules and small pupils, they are one of the most challenging type of cases to do because very often the nucleus is pretty dense and thick as well. So I think it's important to expand the pupil even if you think you can manage, because when you have multiple complication factors, you want to be very safe. So I would routinely expand these pupils, and I will start with iris hooks. Actually, I don't like to use Merlin rings in these eyes because we're going to add further support. So after I've expanded the pupil, I do a capsulorhexis, and if I can, I may even use my Zima femtosecond laser if it's a very, very dense cataract in the operating theater. And then after that, switch these hooks to capsule bag hooks to support the equator. And I then don't worry so much about the pupil expander. And I would straight away insert a capsular tension ring at the outstart. And this will be done by injecting viscoelastic just under the capsule to create space for me to inject the CTR without trapping the cortex. I very often also add a capsule hook to, having all these capsule bag hooks, because I don't want to have a lens iris diaphragm retropunction syndrome, whereby when you insert your phaco with the infusion, you suddenly get this deepening of the chamber because of the contact between the iris and the anterior capsule. Because you're pulling up the anterior capsule and your pupil is kind of still smallish, you tend to have this broad contact and you end up with a reverse pupil block. That tends to suddenly throw the chamber very deeply, and I think this actually makes you lose more zonules, makes surgery so much more difficult because the lens is pushed far deep.
I think there's some issue with Professor Chi's
Connection.
bandwidth.
Allows me to get the lens to a nice anatomical position in order to do all my cracks.
Thank you so much.
Timing of CTR. I mean, when would you insert that CTR? Before doing a phaco or after doing the phaco or before doing a IA?
Always I do it at the outstart before I even do hydrodissection.
Oh.
So that my do the dissection of the space just under the capsule and I insert the CTR. So after that, I use the hooks to support the bag, and after phaco, I insert two capsule segments because this is progressive.
Thank you all. Thank you so much. We've had a very wonderful webinar, and I must thank Professor Chi for staying with us throughout it.
Throughout this, because
A
it is
lot
very
of
late.
time, I think. And unfortunately, Dr. Amar Agarwal, Professor Lahane, and Professor Ragini had to leave as they had to join another webinar. But we've had a very fruitful discussion, I think, in spite of three of our speakers not being there. But we had such wonderful moderators with us. So I thank all of you, especially Professor Chi. I must thank you from the bottom of my heart. And before I ask Bataman to give his vote of thanks, I'd like to tell everyone that we have had a viewership of 6,139 viewers all together on every platform. So that's really great. I think wonderful viewership. And I would request all our MOS members to look forward to our next webinar, which will be on retina, possibly the last webinar of our tenure on 10th of October, which will also be having MMC credit points. So please look forward to that and please do join us. Vardhaman, over to you.
Thank you so much, ma'am. I think today's webinar was special because of so many reasons. And the first being, we had really galaxy of international star speakers. And I think first and foremost, we are very, very thankful for Professor Chi to be available for MOS webinar with all her expertise. And she has actually stayed all the time till the end. So thank you very much, Professor Chi from Maharashtra Ophthalmological Society. We are very, very thankful to you from the bottom of our hearts, and we wish you all the best. Thank you again. We are also thankful to Professor Amar Agarwal sir, Padma Shri Dr. T.P. Lahane sir, and Dr. Ragini ma'am. I think all of them actually brought out the best pearls for very, very difficult situations. And of course, not to mention our very, very eminent moderators from Maharashtra Ophthalmic Society, Dr. Jen Sabate sir and Dr. Shirish Thurat sir, for your very, very great pearls and with your talks, as well as with great moderation and for having a very lively discussion after all the talks. This is also special because this is the first MOS webinar to have the credit points, and after about more than 3 years, we have been successful in getting MOS accredited with Maharashtra Medical Council, and this all our viewers who have logged in through the web link are going to get 1 credit point through MOS. Of course, I'm very thankful to MOS team. Of course, our leader, Dr. Malik ma'am, she has great vision for all our webinars, always involving everybody along with her. With Dr. Preetham, Dr. Bide sir, Dr. Preetham, so all the MOS team that we have, and of course, Ento team for their expertise in the technicality. There are two things I would like to tell at the end is that MOS virtual conference, we have seen a teaser which was shared by Dr. Malik ma'am. So look forward to 7th and 8th of November. This will be MOS virtual conference. Believe me, everybody, this will be a great show with the best of the speakers from around the world. And we are going to have, you will feel that it is like a live conference. So we are going to that extent. And we are taking a lot of trouble under Dr. Malik ma'am to make sure that this will be a memorable one. And again, MOS updation of the membership, at least we are thankful to 1,600 members who have updated so far. And we would really urge to the others who can really update in the next 2 or 3 days, because we have to consolidate all this data and give to our election commission. But thank you again from the MOS. Thank you.
Thank you, and hope to see you
Thank you
in
very
person,
much.
Professor G, one of these days in some meeting. So nice.
Thank you.
Thank you,
Thank you
Professor
very
and
much.
everybody. Thank you, Shirish, ma'am,
Good night,
and
everyone.
Lakman.
Good night. Bye, Dr.
Bye-bye.
Bye.
Take care.
Thank you. Thank you, everybody.
Yes.
Bye.
Thank you.
Thank you, everyone.
Thank you.
Thank you, MOS.
Yeah.